Please, and the 40% of you who have still not subscribed to the Ethicsverse, welcome to the coolest place to be every Tuesday at noon Eastern. If you think fixing our healthcare workplaces can fix our world, we got a real treat for you today. We're going to be diving deep on managing coding updates. This is something that's on all of our radars, something that sometimes can feel a little bit overly complex, and we're going to break down some of the best practices. So let's start off with a massive emoji explosion for the one and only Nicole Emanuel. She is a partner at Nelson Mullins, and they've tried over thousands of administrative healthcare cases. And she's going to walk us through some of the most consequential CMS EM coding changes. And these are really a lot of the places that compliance teams get tripped up. We're going to be talking about what compliance documentation looks like and the legal strategies for defending against overpayment determinations, which none of us like. As we get started, drop your LinkedIn URL in the chat, connect with somebody today. We're getting a lot of great feedback. This episode in particular came from some requests that we received. So we're really excited to have you. Nicole, how's it going?
Going fantastic. How are you?
Very good. So I'm going to run through some quick announcements. Drop that LinkedIn URL in the chat. If you're not, I say this all the time, and I'm going to keep saying it until maybe my last breath. If you're not taking advantage of this unique community that we're all a part of, then you are leaving a lot of impact on the table, and you're probably wasting a lot of cycles, a lot of wasted calories. So connect with somebody today. And as we're going through this session, please drop your questions in the chat, because we are going to be giving away 5 copies. Look, anytime you win a book, you can pick from any of the books in the Ethico library, but we are featuring our good friend Reed Blackman's new book, The Ethical Nightmare Challenge. If you're interested in AI and how to better govern it, this book is absolutely for you. So we're going to be giving away 5 of those. And if you have not checked out our session with Reed on book launch day, like and subscribe to our YouTube channel, and you can check the replays of that, of the ethics experts. All the content that Ethico puts out is there because we love you. Also, because we love you, we've put out a really phenomenal healthcare benchmark report. So if underneath your purview is the hotline, the case management, the investigation process, you're not going to want to miss the industry's only healthcare investigation benchmark report. A lot of great trends to see there, a lot of great data points to benchmark your program against. And again, remember, if you're not in continuous improvement mode, then you're failing, okay? We got to continue to improve. Perfection is an ideal that we must pursue just because it is noble in and of itself. Even though we're never going to reach it, we have to continually try to get better. And the benchmark report is full of great data points, like I said, and a bunch of great tips on how you can think about your data in some different ways, how you can uncover better insights. So much of our job is making better bets with our time to really de-risk the organization. All organizations have a policy management process. We've been getting so much phenomenal feedback on this thing. Anytime you launch a product, it's like when you have a baby. You want everyone to think your baby is cute. Anytime you launch a product, you hope that it has an impact and it solves the problems that you hope it's going to solve. Well, we've gotten a lot of tremendous feedback about our Policy Plus policy management tool that we just launched, our policy management platform. It's called Policy Plus. It's AI backbone. It takes so much work out of it. AI does the work, you make the decisions. It's built with all of the guardrails in place, so it's going to adhere to your AI policy. You don't have to worry about privacy. You don't have to worry about hallucination risk. And you control where those humans or experts in the loop, like our good friend Dr. Hema Lomax says, you control in the process where those humans are in the loop. And, so many of the people that we're talking to are spending so much of their time through some kind of a manual process. We were talking to somebody about, tell us about your policy management system. And they said, well, I am the system. You have policies all over the place. They're on desktops. They're in emails. You have maybe a spreadsheet that you're managing, and it's hard to get the data out of it. And you spend, like I said, so many cycles pulling all of these threads together. The Policy Plus platform, say that 10 times fast, the Policy Plus platform helps to streamline that entire thing, rise to the top of your inbox or rise to the top of your workbench, the things that need your attention, and really collapse down the policy drafting to publishing, process from, 8 weeks, 4 weeks, whatever, into just a couple of days. So if you're interested in seeing that, go to ethico.com and, sign up for a demonstration, a no pitch zone demonstration, and see how this might be able to save you some time and drive some impact forward. That's so much of our job right now. the responsibilities expand, the risk landscape expands, and usually our resources are not expanding along with it. So it's incumbent on us to make sure that we have the right tools and the right frameworks in place to make the right bets with our time. On Thursday, July 23rd, circle your calendars in red, take the day off, or bring everybody on your team. We're going to be giving away 12 credits at least. Assuming you're not double dipping, which you can do, which we won't tell on you for, whether it's for the Compliance Certification Board, for SHRM, or for HRCI. We have 4 phenomenal sessions on Ethicsverse Day 3.0, July 23rd. You are not going to want to miss it. We have some phenomenal guests, some great discussions, and yeah, it's going to be awesome. So last year we broke the record. We should be in the Guinness Book of World Records. Unfortunately, they don't have anything for ethics and compliance yet, but we had the biggest ethics and compliance event in the history of the world, and we're going to be trying to double that this year. So you are not going to want to miss July 23rd. Okay, with that, let's get a massive round of applause, a massive emoji exposure for the one and only Nicole. How's it going, Nicole? You got Nick and Nicole today. How do you like that?
I like it. I like it. Thank you for having me. I appreciate it.
Yeah, absolutely. So we're going to dive in to some of these changes and kind of, you can take control of this. You have a great presentation that we're going to be walking through today. But just to kind of set the stage, why is this such a problem area for compliance? And what should a compliance officer who's listening in really be thinking about and be trying to gather from this this next hour that we're going to spend together?
So E&M codes, evaluation and management codes, are one of the top audited codes in the country. So an E&M codes, it's not just a certain type of doctor or a certain type of facility. It's everything. It's hospitals, it's primary care, it runs the gamut, skilled nursing homes. So it runs the gamut. It applies to almost everybody, and E&M codes are just being scrutinized. One of the biggest reasons that they're being scrutinized, and I will go through this throughout this presentation, is that they are somewhat subjective. So let's go through this. And before I begin, I do want to let you know that one fun fact about me, besides what Nick has already told you, that I've been an attorney for, well, I didn't tell you the years, but it's been 26 years. But
I
anyway.
would never. That's for you to tell.
Well, a fun fact about me is that I got into healthcare regulatory compliance litigation because I used to prosecute providers for the government. So I learned from the government side how to prosecute providers, and I realized that the government really has a broad umbrella of what they go after, and they catch a lot of innocent people in their broad breadth. So what are we going to talk about today? We are going to talk about the different changes to the evaluation and management services and the way records for office visits are coded. These CPT medical coding updates, they're crucial in the healthcare industry. They reflect the evolving landscape of medical procedures and E&M services. So we are definitely going to look into clarifying some recent changes. As you know, the biggest change was 2021, but there were some other changes in 2023, 2024, and I also am going to talk about the ones coming up in 27. So we're going to talk about those changes. I'll offer guidance to ensure compliance with the changes, optimize reimbursement and avoid overpayments, and also present common legal arguments to defend against alleged overpayments. So 2021, that's the big one. 2021 is the year that the biggest change of E&M guidelines changed. On January 1st, 2021, CMS and AMA implemented one of the most significant changes to E&M coding in decades for office and outpatient visits, specifically CPT codes 99202 and 99213. Now, remember, I said office and outpatient visits. That's key. Now, prior to 2021, providers selected E&M levels based on 3 key components: history, physical examination, and medical decision-making. To justify higher level codes, clinicians often felt compelled to document extensive histories and perform detailed physical exams, even when portions of that information did not materially affect patient care. The 2021 revisions fundamentally changed this approach. History and physical examinations, while they're still medically necessary and must be documented when performed, they're no longer used as scoring elements to determine the level of service. So instead, code selection is based on either medical decision making, which I'm going to call MDM, or total physician or qualified healthcare professional time spent on the date of the encounter. The intent was to reduce administrative burden, supposedly eliminate, note bloat, and allow clinicians to focus their documentation on information that's clinically relevant to the patient's care instead of having to do all the rigmarole. So in practice, in 2021, what really let's give a fictional example of an example of what changed in practice. So say Dr. Smith, an internist, seeing a 72-year-old patient with diabetes, hypertension, and worsening kidney disease, before 2021, to support a level 4 established patient visit, a 99214, Dr. Smith often documented, a lengthy review of systems covering 10 or more body systems, extensive past family and social history, a comprehensive multi-system physical exam, even when many exam elements had little impact on the management decisions being made that day. As a result, the note might contain several pages of templated information, much of which was included primarily to satisfy coding requirements rather than to communicate patient care. Well, after 2021, Dr. Smith can focus documentation on the issues that actually drove the encounter, reviewing declining kidney function lab results, assessing medication risks and benefits, coordinating care with a nephrologist, adjusting treatment plans for multiple chronic conditions. The visit may still include an appropriate history and physical exam, but Mr. Smith no longer needs to document dozens of review of systems elements or perform a comprehensive exam simply to reach a particular E&M level. Instead, the complexity of the medical decision-making supports the code selection. So in this scenario, the coding emphasis shifts from how many boxes were checked to how complex was the physician's cognitive work and management of the patient. For providers on the ground, this translates to less documentation focused solely on coding requirements, more flexibility to tailor notes to patients' clinical needs, and reduced duplication in excessive templated text, and greater emphasis on accurately capturing clinical thought processes, risk assessment, and management decisions.
So why has this change then become this kind of recurring source of audit exposure rather than just like the routine housekeeping that it kind of in theory should be?
Well, like I said, the auditors are always going to go to these E&M codes. And as soon as there's a change in policy, for example, this not having the history and the background included in the clinical notes, they're going to look for that. The auditors will look for changes and actually look for whether the providers kept up with the change.
Got it. Okay.
Okay, so now we are on some key 2021 changes. I've already gone through some of this, but let's just emphasize the elimination of history and physical exam documentation requirements, code selection based on MDM or time, new definition of time to include both face-to-face and non-face-to-face patient encounter activities, revised guidelines, and the deletion of that level 1 office outpatient visit for new patients, that 99201. They just eliminated that. And we'll get to G2212 more in the future, but these are the key changes in 2021. Going to 2023. So this change is built basically to simplify the documentation processes. The 2023 E&M revisions kind of extended what the 2021 did. But remember, 2021 did only for office visits. And so 2023 E&M revisions extended to hospital inpatient services, observation services, emergency department visits, nursing facility services, and home or residence visits. So in the 2021 was the biggest change, but then 2023 just broadened it to apply to everything else. So the primary objective was consistency. Prior to 2023, they had, depending on where you were or whether you were in a hospital or whether you were in an office, it would change the guidelines. And this 2023 just kind of leveled the playing field. Now, here is what you do for no matter where you are.
Okay, so 2023 kind of took the ball and ran with it from what happened in 2021.
Exactly.
So let me ask you this, Nicole. I know we're going to kind of keep walking through these, but like for a compliance officer who delegates coding to the billing team, why should we be tuned into these changes? Why should these be something that is part of the, risk surface that we're considering? Just to kind of frame it out.
Well, if you undergo an audit and they allege that you are overbilling, say they're saying you are billing a 99205 when you should be doing a 99204, and they look at a sample of 30 claims, they're going to look at that sample of 30 claims and they're going to extrapolate that error rate. So if in their arbitrary / subjective, however you want to frame it, in their view, you have an error rate of 100%. Say that you extrapolate that over 3 years, you're going to look at, an allegation of owing $20 million. These numbers get very big, very fast. And right. So it matters whether you code correctly and you stay on top of these changes, because not staying on top of them can cost millions.
Yeah, and I mean that point you just made is so important, because they're just grabbing a sample and then they're extrapolating that across the entire operation, and that can just balloon so quickly.
It absolutely can balloon, and it balloons fast. And so that's why you have to defend yourself on twofold. You want to defend yourself clinically and say, hey, you were incorrect when you said that those 30 claims had 100% error rate. But then on another level, you want to say, hey, just get a statistician in here and make sure that your mathematical extrapolation was based on found bases.
We got a great question from Lance here. Do you mind if I ask it now, or do you want to wait a little bit?
No, that's okay.
Yeah, okay. So Lance, thanks for this. Lance says, I'd be interested to see what Nicole recommends on who assigns EM codes. Our organization relies on the provider to assign the codes, and then samples are audited. Our compliance department includes a dedicated EM auditor, so we are on top of these changes. So what do you think about that? Do you have any perspective on who should be actually assigning those codes? And do you have any kind of feedback on Lance's setup from a risk mitigation standpoint?
I think that is a fantastic question. I think that's why we have so many issues. The providers should be the ones that say, okay, this meets a 99205. This is what meets a 99204. But here's the thing, providers are not billers. Right. They're not billers. I mean, so you have billers in place to make sure that the doctors are billing correctly. And there's going to be some, maybe there's some pushback from one or the other. And I think that the biller needs to be able to be so up to speed on the changes or what's going on with these codes that they are able or confident enough to push back to the doctor, because you have to
Right.
remember, doctors aren't billers, they're
And
providers.
doctors are not gods, okay?
Correct.
But there's, this is probably stupid what I'm about to say, so buckle up. But if the auditors are just doing a sample, the underlying assumption, of course, is that, I'm sorry, like if your internal auditors, your billing auditors are just doing a sample, of course, you're assuming then that sample is representative of the broad population. And so we are leaving some kind of an error rate, an unknown error rate, that kind of is the source of some exposure, if in fact it's not truly indicative or truly kind of representative of that broader sample, especially since odds are most likely that an external CMS auditor is going to grab a different sample, just on a kind of a granular basis. Like, how do you deal with that? I mean, you kind of, obviously the answer probably is not having, a biller hip to hip with the doctor or the provider. How do you bridge that gap in practice? You know what I mean?
Yeah. I understand. So when you have the sample or you look at the sample of whomever has grabbed it, you want to make sure that sample is indicative of or demonstrative of what you do every day. And that is exactly to your point. You don't want to grab a sample of all high level billings if that is not indicative of your normal billing. You should have some sort of, I would think, some sort of chart that would have some sort of, here are the lower billings, and then here's the middle billings, and then here it goes down to the higher billings. So you'd want to make sure that your sample demonstrates your practice.
The population of bills, basically.
Exactly. Because if it doesn't, then when you extrapolate, the extrapolation is wrong.
Yeah, exactly.
Mm-hmm.
In your experience, obviously, when you're getting involved, and again, I want to get back to your slides here, but in your experience, when you're getting involved, and I'm just kind of curious, like, is everybody just kind of blindsided by it, where they think that they got their ducks in a row, and then the audit comes in and like there's a massive gap because maybe their internal auditor, their internal billing auditors weren't sampling correctly, or they were applying the wrong codes? Like, what is if the blindsidedness is a recurring sort of theme with the folks that you work with, what's like the recurring source of that, that blindsiding happening?
Okay, so I have two types of clients that come to me. One, and it's the majority, I would say 90% they're gonna be the blindsided. They submitted their request, their production of documents. They got the request for the documents. They submitted them. They had no clue there was going to be any problem. They probably self-audited. They probably had an internal auditor saying, hey, everything is fine. And here's the thing. They probably were fine. These auditors are overzealous. When there is a subjective decision to be made and it's for or against a provider, it's going to be for the auditor all the time. The auditors, that's one of the reasons why my job as an attorney to defend providers is easy. And I mean, not easy, it's very complex, but it's easy because a lot of auditors are not good at their job, and or they arbitrarily pick what is a denied claim and they can't defend it. So when they have me coming up against them saying, absolutely not, there was this medical decision making, this medical decision making, and this medical decision making, how could you possibly have thought that it was a level 4 instead of a level 5? They can't hold their own. And so anyway, the blind side, going back to your question, the blindsided are normally, they don't understand that they really don't have as big of a problem as they think they do, because we can defend it.
So that's a very interesting sort of path, right? Like a lot of times, or we've been talking about this sort of new era of compliance and trying to sort of uncover these false senses of security that we might have in our various different programs or the various different aspects of our program. You think everything is good to go, everyone's read the policy, and then you see a violation of a policy. Or you think, no news is good news, or, we haven't had any, spiking issues on discrimination and harassment or whatever the, topic du jour is. And then you get sort of blindsided by a lawsuit or and I can come up with 100 of these. Okay. So we're trying to figure out, how do we find these hot zones, or how do we kind of take a scientific approach to our programs to uncover, okay, where do I think, I have kind of protection, where that protection is not as sort of strong as I think, right? What you kind of described is a lot of scenarios where you're blindsided. You think you have this protection, you think you have your T's crossed and your I's dotted. You end up getting blindsided by something that's really sort of baseless because of an overzealous auditor who is erring on the side of a violation as opposed to erring on the side of, let's say, objectivity or something. So in those kinds of scenarios, how do you guard against that? Is that just kind of, charge it to the game? It's just sort of the cost of doing business? Or are there things that we can do operationally to lower the likelihood of an overzealous auditor sort of, overstepping their, authority, let's say, or, you know what I'm saying? These sort of false negatives, reduce the false, I guess it's a false positive rate from the auditor's perspective.
Yeah. I totally get that. So, the 90% that are blindsided and the 10% that are not, it's because of what you said, being proactive. Being proactive is the best way to prevent this kind of stuff from happening. So the proactive provider receives a request for documentation and understands that the provider is undergoing some sort of audit, whether it's a Medicare, Medicaid, whatever kind of audit it is, and understands and hires an attorney immediately instead of waiting to get the blow of you owe $20 million. The proactive provider gets the attorney immediately, and the attorney goes through the documentations with the provider. They send them in, they submit them on letterhead that is from a law firm, from that attorney. And you will be amazed at how differently the audit goes when you submit the documentation on attorney letterhead versus when you just send it in yourself, if you can guess the reason.
Yeah, I've rabbit holed on YouTube with these videos of people getting pulled over and police officers overstepping their bounds, only to find out that they're talking to an attorney behind the wheel. Those are some of the most satisfying videos out there. It's the same kind of a thing.
Yeah. No, the proactive provider is always going to be the one that's more prepared.
Yeah. Okay,
so
very good.
We've hashed out these 21 and 23. So then let's go on to 24. And what happened in 24? So 24, the updates wasn't a huge major overhaul like 21 or 23. They were designed to refine, clarify, and operationalize the changes that had already been implemented. Think of 21 as the year that transformed office and outpatient E&M coding, and 23 as the year that expanded those concepts into hospitals and EDs and nursing facilities and home-based care. The 2024 changes focused on making those rules easier to apply consistently, regardless of where the patient is seen. So the overarching goal was straightforward. Physicians should not have to learn a completely different coding methodology, simply because they move from an office to a hospital or a skilled nursing facility or an emergency department. CMS and AMA continued moving toward a unified framework centered on MDM and time when applicable, clinical relevance rather than documentation volume, and this ongoing simplification helps reduce administrative burden when improving consistency among providers, coders, auditors, and payers. So what problem was 2024 trying to solve? Following the 23 changes, many providers were still asking, does the same MDM framework apply in every setting? How should data review be counted? What activities can be included when selecting a code based on time? Are there differences between hospital, nursing facility, and home visit coding rules? So the 2024 update sought to answer these questions by reinforcing a common set of principles across multiple places of service. So one physician can do 3 different settings and bill the same. Going to the next slide. There was also a slight change, and I find this a little kind of beating a dead horse, but they took out the removal of time ranges from both the new and established office outpatient E&M codes and replaced them with a single minimum total time. So, I mean, this is kind of, a little odd, but, instead of going from 15 to 29, they just picked 15. And instead of going to 40 to 44, they just went to 30, which is not that huge of a deal. Going to split and shared services. This was the big change in 2024. Split shared services, it continues to be an important compliance and reimbursement focus area because it involves care provided collaboratively by both a physician and a non-physician practitioner, or an NPP, or a PA. So a split shared visit occurs when both practitioners from the same group practice participate in the patient's E&M service in a facility setting. These settings include, hospitals, inpatient, outpatient, observation services, ED. And it's important to remember that split shared billing does not apply to office or other non-facility E&M services. So the key question for coding and billing purposes is which practitioner performed the substantive portion of the visit. The practitioner who performs the substantive portion is the practitioners whose NPI should be used on the claim. Under current guidance, there are 2 ways to determine who performed the substantive portion. Option 1 is time-based, and option 2 is MDM method. So under option 1, the time-based, the service may be billed under the practitioner who spent more than 50% of the total time personally performing the split shared E&M service on the date of encounter. For example, if a PA spends 35 minutes evaluating the patient and coordinating care while the physician spends 15 minutes reviewing findings and discussing treatment options, the PA performed the substantive portion because they performed more than half of the total time. So in this case, assuming all other requirements are met, the service would be billed under the PA's NPI. Now, option 2, the medical decision making, the service may also be assigned to the practitioner who performed the substantive portion of the MDM. Under CPT 2024 guidance, this generally means the practitioner who performed 2 of the 3 MDM elements and used to determine the code level. Number and complexity of problems addressed, amount and complexity of data reviewed and analyzed, and risk of complications and or morbidity from patient management. The practitioner who performs 2 of these 3 components is considered to have performed the substantive part of the MDM.
Do you find most organizations pick one method over the other, or do they have a bias due to some kind of incentive to kind of choose one over the other? And does that kind of lead into like different audit risk?
I think that is a very good point. I think that providers are going to want to go with option 2. When I say providers, I mean the doctors, the one who is over the NP or the NPP or the PA. They're going to want to go with option 2, the medical decision making, because they're saying, even if I just read these notes for a shorter period of time, I'm still making more medical by just reviewing these notes than what the PA spent in the room. And I can see that being kind of an argument between the 2, depending on how they're incentivized. Yeah, exactly. The key takeaway is, though, that for split shared services, organizations should focus less on who saw the patient first or who documented the biggest note or the longest note, and more on who performed the substantive portion of the encounter. The determination can be based on either time or MDM, but the supporting documentation must clearly demonstrate why the service was billed under that practitioner's MPI.
So Thomas has a comment here. He says, thanks for this, Thomas. Lance, we'll get to telehealth in a sec, okay? Thomas says, just say no to split/shared. Seriously, we have this very limited and watch this like a hawk. Do you think this is the right approach? Just saying no to split shared.
I mean, that would probably save a lot of audits because, again, like I said, the arbitrary nature of medical decision making is arbitrary. It's just the same as choosing split shared. A lot of auditors, like I said, they'll go in overzealous and they will go in and they will find problems where you can arguably not have problems.
And like the burden of proof is on your defense at the end of the day. It's not like a lot of cost for an auditor to just kind of say, oh yeah, these are all problems. And then it's on you to go ahead and defend it. If there's a higher rate of, auditor kind of flagging something on the split shared, I think to your point, it might make more sense to do kind of the Thomas approach of just say kind of no to it. Why wouldn't organizations say no to it? Because the doctor needs to feel important on the way to the golf course or something?
I have no idea. I don't know how how the doctor versus the PA are financially incentivized. I don't know the ins and outs of that. So I don't know why there would be any dispute on how to do this. I would think my only recommendation, I guess, would be that if you're going to do split shared, pick one way. Don't have two balls in the air. Just pick one and just stick with it. Don't change it around.
Which is kind of what Thomas was kind of advocating for, Brittany has something else here I'd like to get your feedback on. I know we have some more stuff to cover, but maybe you can just weigh in on this. Thanks for this, Brittany. She says, can you please provide your perspective on non-physician practitioner, NPP, scribing, specifically regarding the practice of an NPP documenting an attestation as a scribe for a patient history and subsequently utilizing their own professional licensure for the remainder of the same visit?
Ooh, I don't know if I understood the question.
Well, I don't even know if I read it right. So hold on, let me try again. All right, so let me try again. Okay, so Brittany is saying, can you please provide your perspective on NPP scribing, specifically when the NPP is documenting an attestation as a scribe for a patient history and subsequently utilizing their own licensure for the remainder of the same visit? I just moved my hands a little bit on that reread, so I don't know if that helped.
Well, I'm not sure I'm understanding the question.
Okay. Well, ask it again, Brittany. Let's keep moving. And if you don't mind, Brittany, we'll definitely like to come back to it.
Okay. All right. Moving on. Let's see. All right. So the additional 2024 changes, the split shared services, for critical care visits and prolonged services, which don't use MDM, the substantive portion is more than half of the practitioner's total time. We've discussed that. So, and like I said, when we're talking, I think it matters if you wiggle back and forth. I think you should just pick one type and just stick with it. Now I want to talk about that additional HCPCS code, which is the G2211. So in 2024, this was a major coding change. They added on complexity HCPCS code G2211. Sorry. So this was one of the most significant recent Medicare payment policy changes affecting office and outpatient E&M services. This was the implementation of the add-on G2211. Now, historically, physicians and other practitioners have argued that traditional E&M codes do not fully capture the additional work associated with managing patients over time. While a single office visit may appear straightforward on a given day, the practitioner is often responsible for coordinating care, monitoring treatment plans, addressing patient concerns between visits, and managing ongoing health issues over months and years. And so this G2211 It was created to recognize this additional resource utilization and the complexity associated with longitudinal patient care. Importantly, G2211 is not a standalone service. It's reported in addition to an eligible office and outpatient E&M code. So the purpose of the code was really to recognize like long-term primary care relationships. You know, when the practitioner serves as the focal point for the patient's healthcare needs. You know, coordinating referrals, monitoring chronic conditions, that kind of thing. And it also was meant to help when the practitioner provides ongoing care for a serious or complex condition, you know, cancer, neurology, cardiology, something of that nature. You want to make sure that you understand that this code is in addition to what the visit was, and it just represents the fact that you're helping this person through a process instead of just seeing them that day, bye-bye, you know, seeing them that day, bye-bye. No, it's more of an ongoing process and making sure that somebody is cared for. So it is just basically CMS's recognition that healthcare is often delivered through, you know, long-term relationships rather than isolated encounters.
Right.
I mean, I give my primary care physician a Christmas present every year. You can see how those relationships become close, and it doesn't just last over a single office visit.
Right.
And
so, sorry, let's circle back to this question from Brittany. She said, basically, can the NPP scribe and perform a split shared? Kind of, can they act as a scribe and a clinician?
Ooh, I don't know if I know the answer to that off the top of my head. That is something that I would look into, and quite
1,000 points for Brittany stumping you. She stumped you.
That's a really good question, because if they're putting the scribe hat on, can they also wear their clinician hat at the same time? And I'm sure there's a rule.
All right, very good. Thank you.
No problem. Oh, okay, so going back onto the G2211, there's no specific diagnosis required, any diagnosis. And let's see what else. It may not be billed with code sets for E&M services like hospital and patient, but it is a good code. It's a good code that primary care, it was almost like CMS recognized that primary care physicians of all physicians tend to be underpaid and overutilized. And it was just a bump in their pay for what they deal with day to day. Can you see that one?
Yeah.
Okay. For some reason, it's kind of blue on my side.
Okay, yeah. It says 2024 major EM coding changes, add-on complexity, HCPCS code G2211.
Yep, HCPCS. So all rules for reporting office E&M services apply. You don't have to have additional documentation, and the information included in the medical record or claims history. We don't have to add additional documentation to put that G2211 on. If the patient is a long-term patient, you can just add that code. It was as if they just gave them a bump in their pay. Does that one say payments will be denied, reported at the same?
No, we are looking at the telemedicine one right now. Okay, yeah. So I just put it back to the payments will be denied.
Okay, thank you. So this slide highlights an important limitation relating to reporting the G2211 add-on code and the ongoing evolution of CMS policy regarding when it can be billed. So it's an add-on code that recognizes, additional complexity when a practitioner has an ongoing relationship or a serious or complex condition over time. So what does this mean in practice? CMS will deny payment for a G2211 when all of the following occur on the same date of service. An outpatient E&M visit is billed. The same practitioner reports modifier 25 with that E&M visit. And the same practitioner also reports a G2211. The services are provided to the same patient on the same day, and all that happens at the same time, it will be denied. The purpose of this restriction is to prevent G2211 for being used in situations where the E&M service is already being separately identified as a significant, separately identifiable service through modifier 25. So let me just think of a hypothetical. Dr. X is a primary care physician, and she sees a patient for routine follow-up of diabetes and hypertension. During the same visit, Dr. X manages the patient's chronic conditions and adjusts medications. The patient also receives a minor procedure, such as a skin lesion treatment, that requires a separate E&M evaluation beyond the procedure itself. Because the E&M service is separately identifiable from the procedure, Dr. X reports the office visit with a modifier 25. Even though Dr. X has a long-standing relationship with the patient and serves as the patient's primary coordinator of care, that G2211 cannot be separately paid on that same date of service because the office visit was reported with a modifier 25. So if you do a 25, don't do a G2211. That should be on a sign. If you do 25, don't do a G2211.
We need shirts.
Yeah, we need shirts to explain that. Okay, so telemedicine office visits. We all know that telemedicine is now just used everywhere and all the time. COVID helped with that, and Congress has helped us continue it. So there have been 17 new telemedicine codes and guidelines for reporting. Whew, it's a lot. You've got to stay on top of all those. There is a new virtual check-in code to report evaluation of whether the patient needs to be seen in person. That's a new one as well. All right, so let's talk about some compliance aspects and takeaways. So there's been a shift toward medical necessity instead of the history and physical exams, as we talked about from 21. So still document the history and physical exam, but avoid cut and paste. That is the biggest thing. That is such a big red flag for auditors. Make sure you self-audit. Make sure you document encounter specific details. Don't just gloss over things. Use clear, concise language. Make sure you explain why the decisions were appropriate. And going to choosing to go with MDM or total time spent with patient, choose one or the other. Don't go back and forth. Choose one or the other.
I mean, how much of this is just kind of a game of hacking the auditor, throwing some misspellings in there so it doesn't look like copy paste, having one consistent approach? What is in the auditor's mind? I know you were kind of on that side to some degree in the past. Maybe overzealousness notwithstanding, that sort of overzealous bias notwithstanding, what is kind of in the auditor's mind? Is it just kind of normal? Is it what any auditor would be looking for?
Yeah,
what I'm saying
auditor.
Yeah, okay.
Go ahead.
I'm just saying, at some level, it's a human being. And I'm saying, aside from their, if you're a financial auditor, that's kind of the world that I came from before I got into this game. if you see someone's books are a total mess, you're going to be like, okay, there's absolutely an issue here. If you see that everyone's, their financial records are totally dialed in, the financials come out at the same time every single month, the process is followed. Like you can tell very, very quickly if the house is organized or not. You know what I'm saying? If it's a mess or it's an organized house. And despite what again, I'm talking financial, despite what financial auditors, claim to be highly objective and so forth, there's a tremendous amount of subjectivity that comes into ultimately the report that goes along with the financial statements. I would imagine that there's a sort of a corollary on this side because it's human beings sort of doing this work. And I'd love for you to kind of speak to, you said some very specific things on this last slide. Don't just copy and paste. That's a trigger. That, be very sort of articulate and be very specific about the rationale behind the service that was provided. Though all those things seem like headwinds for the overzealousness that might be sort of inherent in an auditor.
Yeah, and kind of what you were going to, even though there's defined rules and procedures of like how to bill and what to bill, the process still is in a significant amount of professional judgment and interpretation. Right. I mean, on both sides, on the auditor side and on the provider side, or the biller side, going to whether it should be the provider or the biller choosing the CPT code. But regardless, but both sides, there's a lot of professional judgment. And that, again, is why it is so easy to argue back and forth whether, I see it blue, I see it green, I see it blue, I see it green. Like, how do you rationale that? But eventually you get in front of an independent arbitrator who looks at both sides and determines which is which. And I can tell you that the providers have a lot better legal defense on their side because in the Social Security Act, in the Social Security Act, there are defenses built into it to protect providers just for this very reason. There is called the treating physician deference, where the auditor is supposed to give the treating provider the deference of whether or not something was or was not medically necessary.
Yeah, kind of tie goes to the runner. You're supposed to kind of defer to the decision that was made by the physician, in theory.
Exactly. That is exactly correct. That is correct. I'm going to go to the next slide. Now, this is just a slide to show, hey, you can maximize payment, reduce stress by knowing how to do this. Isn't that such an easy sentence that's so hard to do? It's like, hey, you can maximize payments by getting it all right.
Right.
So good. But in all honesty, I mean, this is the thing. Like, one of the challenges with the evaluation and management coding is that, as we've said, you've got professional judgment and interpretation. Two experienced professionals can sometimes review the same encounter and reach different conclusions about the appropriate code level, particularly when distinguishing between mid-level and higher level services, such as like the 99214 versus the 99215. But that very statement, the fact that two experienced professionals can come to two different conclusions, is the very core of why I am sitting here telling you, if you have an allegation that you owe money, appeal it. Do not just say, okay, and pay the money. Appeal it, because you can argue your way out of it.
So I'd love for you to share a little bit on, like, we talked about all these reforms in 2023 and 2024. Where have you, I'd love for you to kind of share, like, where have you seen the most confusion? Where have you seen the most kind of recurring issues? And what do you think the new kind of compliance lift is on every new layer of these rules when they take effect?
That is a layered question.
I'm a layered guy, Nicole.
Well, I'm going to just want to give some defenses on how, because everyone's going to get accused of having overpayments. No one's going to have, in my experience, and maybe it's because only people come to me when something bad happens, but in my experience, there's never been an audit that the auditor came back and said, well done, well done. You
Yeah.
wonderful, perfect documents. I've never seen that. So we need to make sure that you are proactive, get ready for it, and then think about the defenses that you can have if you are alleged an overpayment. So the medical necessity, this one is probably the biggest reason that claims are denied, not having medical necessity. But this is what I have found. There is no peer-to-peer review. I have had dental hygienists review oral surgeons' documentation and claim that there was not medical necessity. And I'm sorry, I don't think a dental hygienist can determine medical necessity for an oral surgeon. I've also
Yeah, what do they know?
I know, right? Well, I'm sure they know a lot.
I'm kidding. I'm just kidding.
I'm sure they know a lot, but I don't know about medical necessity on an oral surgeon level. So there's also a lot of, you need to make sure that there's lack of clear guidance. So some of the policies that are written for all these different CPT codes, I'm sure, as you are aware, healthcare providers, they change year after year after year after year. And when something as small as, a government may do this to a government must do this, these little teeny changes, you need to make sure that you are aware of them, because a lot of the auditors, if they're looking at dates of services for 2024, they'll accidentally use the new policy dated 2026 when you could not be held to the standard of 2026 if your date of service was 2024. So make sure that the policies are being used are correct. Make sure documentation standards have been met. Minor errors are de minimis. I want to emphasize this because not all documentation errors require a 100% recoupment. Think about it. A provider provides a service that's medically necessary to a patient who receives it. There is a service given. There is no reason that if there is an accidental error that provider should pay 100% of that back, especially when actual services were rendered. Looks like I'm running out of time. Should I continue to the next slide?
Yeah. Keep going. And then I got a doozy from Lance here that I'd love for you to weigh in on.
Okay.
Lance has got some good comments today, I got to say.
I'm impressed. Well, going to appealing, I really want to hit this because I want to make sure that everyone.
This is a critical point that we're about to cover here.
Yeah, appeal everything. If somebody says you owe $100,000, $1, $1 million, appeal it. Everything is so arbitrary and subjective. You have the right to dispute. You have the right to appeal any audit finding. There is a process that you may go through, whether it's Medicare, Medicaid, whether it's through a contractor that has been hired by the government. Regardless who is telling you owe money, you have a right to appeal. Retain legal counsel and make sure you do not miss any deadlines. Make sure you hire your attorney, not one day before the deadline. Make sure you get your attorney quickly. You don't want to miss any deadlines. And with all that, I feel like I am finished.
You thought you were finished, but we're going to drag you back for two more quick questions. But thank you so much. Okay. Let's get a massive emoji explosion for Nicole. This was actually very interesting. And just the nuance in it creates so many, challenges. You got auditors just kind of shooting from the hip, calling everything a violation. That's great advice, especially when we have faith in our program that we're, putting good faith effort to, apply processes or apply our coding policies kind of consistently. There's a lot of freedom in what you just said to, appeal these things. Look at that explosion of emojis. I love it. Okay. So Lance said, don't go back and forth. I thought the provider / coder could always pick the one that gave the higher code as long as documentation supports it. Isn't each encounter supposed to stand on its own? When we audit, it doesn't matter if the provider uses time, MDM, or a mixture in the sample. As long as the documentation supports it, it's fine. Why should there be only one way over another?
That is okay. So that's a good point. I completely agree with 100% of what they said. You can go back and forth. You can use for one visit, time, and then another visit, medical termination. There's nothing wrong with that. You are correct. I'm just saying maybe like a little bit of like trying to stay away from audits targets is to stick with one. I mean, I think if you go back and forth, there's a way to argue that you should have used this in this case. You should have used this in this case. I don't think there's anything wrong with it. I just think that it gives you more that you're going to have to defend.
Great. Okay. Yeah. I mean, at the end of the day, everything is it's a poker game. It's a bunch of imperfect information, and we're making bets with our approach and our time. And there's always going to be things, there's always hands that we should have won that we lose, and, ones that we have to kind of double down on. Okay. So we are almost right at time. I had an AI question. It can't be a webinar if we don't talk about AI, but we're going to have to ask it next time. Thank you so much, Nicole. This was absolutely phenomenal. Hope you all can join us on Thursday. We are talking to the one and only Mr. Zach. He is back, and we're going to be diving into a really great session on Thursday. And then the following Thursday, we got another great session. So, every Tuesday, every Thursday, this is absolutely the place to be. And let me just tell you what the sessions are. Risk relationships, rethinking ownership across the enterprise. This is going to be phenomenal on June 18th, and on June 25th, we are going to be doing my favorite of the quarter, trending topics, the hottest topics in ethics and compliance in HR. So you're not going to want to miss it. Love you all. Thank you for joining us. We'll see you Thursday.